welcome to another episode of Empower Speaks Healthcare Talks. As always, I'll give you some background information of what this podcast is. So as the name suggests, the idea is to empower you. Whether you're a patient, whether you're a clinician, whether you're an individual in senior leadership within the healthcare system, or if you're an entrepreneur in the healthcare space, the idea is to bring various guests and kind of pick their brain, understand some of the challenges that are happening in the healthcare system, how to navigate them. So regardless of what position you are in, the knowledge that we can pull from these guests can empower you and allow you to navigate accordingly. So, I have a very special guest today, Dr. Karim Jessa, who is the CMIO, so the Chief Medical Information Officer at SickKids Hospital. He is a ER, so an emergency room physician by background. Now, before I hand it over to him and we can pick his brain a little bit about his journey, I always want to share how I met our guest. And so, myself and Dr. Jessa go back way, way back. So as I've shared previously, after I finished my undergrad, I went to pursue my master's in physiotherapy at the University of Toronto. So my goal was to be a clinician, but unfortunately I got injured, and so I could not continue that. So I was in that place. I was trying to pick up my pieces, figure out how to keep moving forward, because I do love healthcare and I needed to find another way to be able to contribute. And that's when I came in touch with Dr. Jessa. He's been a mentor for me since then. So this is dating way, way back, and he's helped me navigate throughout my career. So super grateful to have him in my life, but also for him to agree, no questions asked, to be a guest on our podcast. So I hope you'll learn a lot from him. So Dr. Jessa, I'm going to hand it over to you. If you could share a little bit about your journey. You are a practicing ER physician. And so alongside that, being able to continue practicing, being the CMIO at SickKids, you practice at various hospitals, including SickKids. You also are faculty at a couple of academic institutions. So you do so much. There's more accolades, but I do want to allow you to share about your journey, starting off as a physician. Did you always know that you were going to evolve into a leadership position, specifically in the digital health space? So if you could just share what that was for you, how you came into the space. So please, Dr. Jessa, take it away.
Well, thank you very much, Fahreen. It's just really a pleasure and an honor to be with you and to be in the same environment as a number of previous guests on your podcast. And congratulations on this initiative. So well done to you. Really, it's been great to be part of your journey through your career. So happy that I've been able to provide value. And so you asked if I thought I was going to be a leader in the digital space. I had no idea. I always knew I wanted to be a physician from early days in junior high school and high school when I was part of St. John Ambulance and providing leadership there and providing first aid to events at various events through St. John Ambulance through volunteer work, and then had the path of somebody who's going through university, immigrant family, no doctors in the family, and having to strive to be a physician. So I was able to become a physician, thank God, and where I am now. And in terms of technology, I've always been a technology geek, if you'd say, from the time of undergrad and from the time of medical school, keeping a notebook with me with all those medications and special notes that we'd have to keep. I graduated to a sharp 128K organizer. That was really amazing at the time, so I could keep my medication dosages there. Then graduated to, I'm really dating myself here, to a Palm Pilot, and then a handspring visor, and then all those early devices. And then I fell into sort of a physician IT advisor role. When I came back to Canada, I was in the Middle East, got involved in some health records deployments there, and really got the bug at that time. That was in the late 90s, early 2000s. Came back to Canada and became a physician IT advisor, CMIO at a community hospital in Richmond Hill, and then became CMIO for the last 13 years at SickKids. Helped navigate the organization through a large electronic health record implementation in 2018, and now trying to embed AI into that work and trying to create value for our clinicians.
Yeah, no, that's
So in a
incredible.
nutshell, it's been a great journey, and happy to share my thoughts.
Yeah, no, absolutely. There's so much to unpack there, and your journey is incredible. And I love how through your journey, like you said, you've been there prior to digital tools like we very commonly electronic health records, but you were, like you said, you had paper documentations. Even some of my physicians, like my optometrist, he's more seasoned, and he's told me, Franny, he has his files like there. He has mine since I was a child, and he told me, Franny, I'm retiring soon. I am not transitioning over to an EHR. He's like, I don't need to. So the fact that you have seen that transition, there are a lot of digital health tools, but I feel like electronic health records were kind of, the pioneers of that very much that change. So if you mind just sharing a little bit about that journey from seeing that you've seen so much, whether it's resistance, whether it's uptake, if you could share a little about your journey of having that adoption, like you said, empowering your clinicians, in turn, even your patients. If you could just share any tidbits, any nuggets on how that journey was and what kind of excited you, or what were some challenges that you were like, oh my goodness, this is what we have to do, or where you said you were in Saudi Arabia, like pulling from that or the Middle East and coming here, did you see nuances? So however you want to take this, I know that's a very loaded question, but however you want to navigate it and share with us and take us through that journey that you experienced.
Sure, and I'm cognizant of your previous guests, and I would recommend everybody to listen to the previous guests as well. Dr. Darren Larson, who was a mentor who actually hired me at Mackenzie Health way back when as a physician IT advisor, and then I heard the podcast from Scribeberry, and so I think it's really important that anybody who wants to get into this space, wants to bring in a digital tool to the market, really focuses on one thing, and that's what's in it for me as a clinician and how is it going to help my workflow. Too many times we have entrepreneurs, vendors coming in saying, I've got a solution for your problem without understanding what my problem is. And so, there are always solutions looking for problems, whereas we have problems looking for solutions. And the key is being able to bring those two together. So I think it's been a real interesting journey, and in Ontario we're still going through that journey and on interoperability, and we're about, I would say, 7 to 10 years behind what's happening in the U.S. The U.S. had a huge impetus with the High Tech Act and the 21st Century Cures Act and all those acts that promoted EMR use, meaningful use as well, and Canada has tried to tag along. And now we're having leadership in Ontario and in other parts of Ontario that are deploying widespread electronic health records for population health needs, for safety and quality, because we know that the more advanced digitally you are, the more enhanced quality and safety will come to the at least the acute care space. But there's still a wide divide between acute care and primary care as well in terms of interoperability and sharing of records. We're going through that now with sending records from hospitals to primary care physicians' offices. How do you send it? Are you getting duplicates? It's quite an interesting environment, and the Ministry of Health in Ontario is trying to do their best, but I still think we have a long ways to go. So I think focusing on workflows and focusing on clinician or physician wellness, NPs, physicians, nurses. And remember, electronic health records started off as sort of billing tools, and some of those tools in the US were really focused on documentation and making sure that you met all the levels of service to get reimbursement. Our motivators and drivers here in Canada are a little bit different. Whereas we can actually focus on outcomes and quality. Not to say they don't, but our billing systems are a little bit different. Reimbursement is not as tied to documentation as it is in the US. So we can approach it a little bit differently. And so from a point of view, I think you asked a question of adoption. Really important for us to consider what that adoption means. And to get adoption, you have to basically understand what the workflows are for clinicians and how we can work with them in co-design. And that's the work that I do as medical informaticist, to be able to not make the assumption that as an analyst, as somebody who's building the system, will be able to understand. So I'm a big proponent of sort of going to Gemba. And for those of you who know that term, going to Gemba, watch what they're doing, Don't assume, because then you have work is imagined versus work is done. And we're very good at workarounds and figuring out how to game the system. So it's really important for us to understand. Does that answer your question,
Yeah,
Fahreen?
no, absolutely. There were so many nuggets there, and I'll kind of extract some of those. I think the first piece where you mentioned that you need to understand what the problem is, what the problem statement is. When I was at the FLIP conference, the Future Health Informatics Policy and Leadership conference at the University of Toronto this year, the director at River Hospital, Zara Shirley, had mentioned the same thing. She presented a framework where she said, before you go ahead with anything else, figure out what your problem is, and then you can solve it. So I think that's what you kind of reiterated right there from the get-go, that you need to understand that. The second piece where you said, where is it, what is it in it for me? I remember when I was working at one of my vendors, he was a ER physician as well, and he worked at UHN, University Health Network, and they were implementing Epic. And he told me he opted to be a super user. Yeah, there's some incentives, like you get paid more and all that to do that extra training. But he said, I selfishly did it so that way I could understand how to navigate it so it wouldn't impact my patient care with my patients and made it easier for me. I helped my colleagues, but it was more selfishly, like, to be completely upfront. So I think to your point, there's always, what is it in it for me? If I'm going to do it, I need to benefit from it. And the other piece that you said about workflows, I think a lot of people underestimate the purpose of workflows. For the same vendor, they were a communications app, and we tried to do a pilot with an organization that used that the physicians, they just used Teams to communicate with themselves. So they didn't use WhatsApp or iMessage, and our app kind of replaced that, but it was PHIPAA and HIPAA compliant. And no matter how hard I tried, so 30 days, 60 days, 90 days, they did not adopt it because they didn't have the workflow for it. I was forcing a product that they didn't need. So I think to your point, it's very important to be cognizant of that. Now, talking about all these pieces and workflows, you are right now in the pediatric space, right? You are at SickKids. I wanted to take a step back, and we'll dive into digital health in a little bit, but I did want to hone in on some of the challenges that pediatric patient populations are experiencing right now. And the reason I think this is so important is a bit earlier in this year, Deloitte held a webinar where the CEO of SickKids, Dr. Ronnie Cohen, was on it, and they were asking about what were some of the challenges, and he kind of highlighted precision medicine, where there are, advantages to it, but there are some nuances that you have to account for some patient populations within the larger group. And so I wanted to pick your brain on if you could share what those challenges are that you are facing as a CMIO at SickKids that you're trying to tackle, whether it is the shortage of family physicians, you name it. So I'll allow you to take us whatever way you want, but to kind of enlighten the audience on what those challenges are.
Well, thank you. And Ronnie is a great supporter of us at SickKids, and we're grateful for his leadership as well. And he's a good personal friend as well. So I think he talked about precision child health, and we're really moving forward with that with some huge initiatives at SickKids. And the idea is getting the right treatment to the right patient. So as you know, a lot of medications are marketed and will not have an effect on patients. And so how do you then selectively prescribe? Or some medications can actually have adverse reactions in patients because of their genetic makeup and their genes, essentially. So they may not be able to react, or they may overreact to a normal dose that you and I would have. But a specific patient, because of their makeup, would react in an adverse way, or the medication may not even have any effect on them. And we have a number of medications in that. So we're doing currently just about to do a little pilot study on the smallest of babies, looking at pharmacokinetics for some of the seizure medications that neonates can sometimes get seizures because they're preemie as well. And so we're looking at specific indicators on a specific baby. What's the optimum dose for them for that medication? We're doing some preventative work and some predictive work on sudden cardiac death. We've put something in through our cardiology center on predicting which kids are at risk for sudden cardiac death because of hypertrophic cardiomyopathy, which is when the muscle in the heart gets hypertrophied or gets very strong. And so there's some work being done there. Some of the challenges in pediatrics is in terms of proxy and confidentiality. So how do you capture information as a newborn when somebody as a newborn comes in and registers at the hospital, what typically happens is a phone number is required or an email is required. I don't think yet newborns have phone numbers or email addresses, but typically it's the mother or father or the caregiver's phone number gets put into the demographic field in the electronic health record, and that stays with the child until they're 12, 13. But what happens when they start getting maybe pregnancy testing at whatever age, start going on some medications or have some confidential or sensitive information? Do you want those records and notifications to be going to the phone number on the patient, which might be the mother or father? And how do you preserve the confidentiality? So those adolescent issues are important. And we're working with our electronic health record vendors to try to make sure that we capture the information, because the quality of the information is really important early on. So we talked about that. We talked about, we also have concerns about transitions of care. So from a pediatric perspective, we are doing great up to the age of 18. Then what happens? Then they have to move to another hospital. For us, sick kids, they have to move to UHN across the street for their complex medical problems. How do the records go back and forth? Right now in Ontario, we have several different vendors for electronic health records. How does that record move forward in a discrete way? We don't want patients to carry a big piece of paper or anything like that, or a big chart. How can we move that we can move that electronically in an interoperable way? What are the standards as well? This is apart from Alberta, which has a provincial system. Quebec is moving to a provincial system. Newfoundland is moving to a provincial system. Nova Scotia is moving to a provincial system. Ontario, not so much. But, potentially there's other solutions to that. Transitions of care, interoperability, precision child health. Those are to name a few of the challenges in pediatrics as well. And at SickKids, it's about specialty care, and then how do we provide equitable care as well. And I think there's a huge potential for this in terms of mobility as well. We're trying to expand our patient portal and the sharing of information. How do we share information with patients? There's an initiative in the US called Open Notes, where all the records are mandated to be shared in the 21st Century Cures Act in the US, where it's mandated, you get reprimanded, and you can get really penalized for not sharing records. In Canada, we don't have that yet. Some organizations and hospitals are doing it automatically, so sharing lab results immediately. If you go to Life Labs or Gamma, you can get your lab results right away. In some hospitals, you can do that. In some other hospitals, you can't. And it's really a balance that we're looking for.
Yeah, no, that's incredible. Thank you for walking us through all those pieces. And the piece where you highlighted about where, when a baby comes in and you're trying to build their profile in the EHR. Even right now, I work on the vendor side. We are a telehealth and patient portal. And with my clients, I have the same issue for pediatric patient populations. A lot of the time, it's the parent's email or their phone number. And like you said, should some of that notification be going to the parents? There is that confidentiality piece. I know, to be, completely upfront, yeah, some parents they're like, regardless, my child is young, I'm going to see it all. But like you said, we have to be cognizant of those pieces. And also the transition. Like you said, once they are 18, is it still going to be available to the parents? How do you navigate that? So I think that point is very much real. It is applicable in so many areas. But kind of pulling from that, we highlighted some of those, some of the challenges that you are facing. As the CMIO, what would you say is the number one challenge that you guys are tackling as a whole at SickKids that you think is very much applicable? Whether, like I mentioned, whether it's something as family physicians, when in the community, when, children at large, that can cause a lot of visits in the ER, because it's an ER, right? That any child can come in that seeks care, that requires care. So based on that, how do you navigate that? Or in your perspective, what would you say is number one? This is what we need to target for our children so they can be healthy and they can get the care that they need.
It's a great question, and I'm finding hard to find one, because we're trying to fight so many fires,
Right.
and there's a whole transition from clinician wellness, to make sure that people are feeling satisfied in their work with the level of burnout. Related to that is making sure that the tools that we are providing to them are bringing them value and bringing patients value. And I think it's just trying to work with limited resources as well. Um, you know, so there are a number of things that are challenging for us. A lot of this also has to do with data quality and how you capture information. So in those days, and I think technology will help us in those in the future, in those days where you could simply just scribble a note on a piece of paper, put it in a chart, and it sits there. Whereas now we want more structured data instead of unstructured data to be able to put in so that we could derive and drive population health, the use of registries to be able to identify patients. And how do we do that with balancing the time it takes to put in structured data versus unstructured data? So dictating completely unstructured data into a field and then having somebody have to read it, extract that information and abstract it into a registry. Those days, I think, hopefully will be gone with the work of large language models and being able to do that. So I think the AI scribe technology, which we are going to be piloting very soon at SickKids, is going to bring value and the ability to drive downstream efficiencies from using AI. And AI will be sort of like the augmentation of the clinician workflow. Will it replace clinicians? Unlikely, but will it be able to be my right hand, just like Harrison's textbook was? Will AI be able to help with that? Doing it properly is going to be really important. Making sure it's equitable, it's explainable. You don't have bias, and it's implemented in a workflow-oriented manner. That's the work that I do, the clinical informatics work that I do along with my CNIO at SickKids as well. We work and we've got a whole team of informaticists who make sure that we understand what the workflows are and be able to implement AI tools and AI solutions to be able to solve some of those challenges that we're facing.
Yeah, no, and I think you highlighted such an important piece there. Clinician burnout, right? That is so prominent. We see that, especially we saw it during the pandemic. And so a lot of these tools is to empower the clinicians. For them to be able to provide that care to the patients, they need to be equipped, they need to be empowered. Otherwise, they won't be able to. And so building off of that, being able to apply tools, like you said, at SickKids, you're planning on piloting an AI scribe. And so building off of that, if you can elaborate, based cognizant of confidentiality, but if you could elaborate on using that tool, or how that pilot is going to be going about, or are there other AI tools or digital health tools that you've seen that you can share some stories with us that you have seen direct improvements, or anything of that sort that you thought was like, what, that did help my clinic, I could see that over time. Any way you want, any stories that you could share with us.
Yeah, sure. So I think that the documentation burden has been clearly articulated by your previous guests as well. The ability to capture a note in the moment and then close your note, not having to spend hours at night documenting. We've got tools in the electronic health record that actually can quantify how many physicians are spending time after hours to document. I could see that. It's not available to everybody. I could see that, and I can then come up with solutions with the clinician. Some of the clinicians say, Karim, I'm happy to do it at night after the kids go to bed because I can leave my clinic, pick up my kids from school, take them to their activities, and then when everything is quiet with my cup of tea, I can complete my charting at night. Some people do it willingly, some people do it unwillingly. But what the AI scribe technology has done in over 300 implementations in the US and in other sites in Canada is it decreases that level of documentation burden. So you can close your note pretty much after you've seen the patient or at the end of your day. And what really matters is the ability to capture relevant details of the patient encounter. So some emergency physicians I know will go see a patient, take a little piece of paper, just write a couple of notes, see a bunch of patients, and then at the end of their shift, they'll dictate their notes. I don't do that. And it's really hard for me, and maybe it's my age, but it's hard for me to remember what did Fahreen say or what did Johnny say, what did the mother say, because you're tired at the end of your shift. Imagine that cognitive load of trying to do 20, 30 patients at the end of your shift or at the end of a busy primary care clinic shift. If you have a tool that can capture that information right up front and summarize it for you, you now don't have that cognitive burden to be able to do that. You can comment on like what's the return on investment and everything like that, but what's the return like if you can have a clinician practice a little bit longer, enjoy the work that they're doing, I think that's really valuable. Another tool that we're going to be implementing is a model, an algorithm that'll predict which kids will vomit after starting chemotherapy and how can we prevent vomiting. And that's really relevant, and we'll be able to hopefully decrease chemotherapy-induced vomiting as well. We are going to be introducing a chatbot agent, less sexy, not clinically facing, but for HR. We all have hundreds of thousands of policies, but how do we read those and how do we put those forward? So I think some of these agents, the chatbot agents, agentic AI is going to be really amazing for us, and hopefully we'll try to improve the efficiency of how we do things eventually in the future.
And just a follow up to that, when you say like HR policies, do you mind giving an example of how that, like, is it like policies on how care is administered, or do you mind just elaborating what an example
Yeah,
would be for you to apply that?
more along in terms of like what's the how many vacation days do I have in a year, and you can actually put that in a little chat agent. Many of us use that. If you try to chat with Air Canada or Rogers or anything, they've got these chatbots already implemented. So I think that's going to be really that we're going to try to do that on the inside. It won't be really clinically facing right now. We're not going to be asking clinical questions. It's more on hospital HR policies, essentially. I think one of the great tools that's going to be able to happen, and one of our electronic health record vendors is trying to do, is you're going to be able to query the whole database of records and a consolidation of records of patients like mine, for example. And the system might be able to identify similar patients across North America potentially. And once you have that, you can actually see how was this patient, a similar patient, 25-year-old, a 16-year-old, 12-year-old with these kind of parameters. What was their journey? But then again, that's predicated on having good quality data. So, data quality is going to be key, and being able to capture it in a succinct manner is going to be really important.
Yeah, and I think that's so important. I know a couple of times you mentioned the importance of collecting that data and in a format that is digestible and can be used. So right now in your current state as SickKids, are there parameters to enhance that data quality, or or any thoughts on that? How you have kind of reinforced the importance of that, and I completely agree. But any thoughts on that, or in general to ensure that we are being able to, or what would be some of the challenges that are not allowing us to do so?
Well, no, I think the challenges are really around workflows and being able to do it in a regular format. And so what do I mean by that? It means that how can I then speak and interview a patient and have those nuggets of conversations being captured. I think the future will be really interesting to be able to say, and we see that happening in pilot right now, where I might say, okay, Fahreen, I'm going to prescribe you Tylenol, 2 tablets every 4 hours. And imagine the AI will be able to listen to that and have a prescription already teed up for me. And then make my workflow easier, and also capture that I've ordered Tylenol for you, or acetaminophen, if we're not going to use name brands, but we'll say, acetaminophen for you at that dose. Or, oh, so you tell me you have, heart disease, or you have something, and it'll capture that on the problem list, and for me to verify. So really, really interesting. I think the future is very bright, and you're going to see an exponential rise in that functionality. So yeah, it's about being able to easily capture data. A lot of our clinicians are used to doing that, so they capture structured data because they are contributing to registries or they have research in mind. But some of the more free-flowing problems are not captured discreetly.
No, and I think that's so important how, and I appreciate you kind of explaining that because I think these problems are kind of highlighted a lot that, okay, we need to collect this data, but I think understanding why. So I appreciate you kind of breaking it down in an indigestible way so that the audience can hopefully kind of pick up on why that is so important, even to for us to build off of that for future tools and all of that. Right now, I want to take a step back more, hone in on your personal practice. So I know you are a practicing ER physician, emergency physician. You practice at SickKids, so pediatric patient populations, but you also practice at other community hospitals, so North York General, what have you. So correct me if I'm wrong here, but you also serve outside of pediatric patient populations. Do you also serve and take care of other populations? And so with that experience, would you be able to draw parallels or comparisons, whether it's when you're providing care to these different populations or the tools that you use? Do they differ when you are at SickKids and serving pediatric patient populations and then when you're in the community at North York General, what have you? If you're able to share your personal experience when it comes to serving different populations, the various tools, does it differ or is it the same? If you can give us a bit of highlight or insight into that.
Sure. I think we use different electronic health records between SickKids and at North York General. Both of them are very good. I they're you just get used to how you do your work and you adapt your workflows. Physicians are very good at adapting workflows. They're very good at adopting technology as well. And again, if you build the system for the clinicians, it can help. For pediatrics, you're not only treating the patients, but you're also treating the parents or the
Right.
caregivers, right? So it's two people that or two groups of individuals that you're treating, and everybody wants the right thing for their kids as well. They're the most important thing. So not really any different. I think it's all about the people and the processes that you have and the technology. Sometimes working at two sites, and I do see adult patients as well as pediatric patients. It's just different, and you appreciate the positives and the negatives and the differences. And a lot of these things are on process. So it's not all about technology. It's about different processes. How do you send, for example, at one organization, if we need to send somebody to a clinic, we print out a piece of paper electronically, we write it out, and somebody faxes it to the clinic. At another, at SickKids, it happens electronically. You put a referral order in, and that's it. That's all you have to do. So one is more paperless than the other, but everybody's on a different journey. Everybody's on a different journey, and eventually, hopefully, in the back end, you'll be able to get the patient the right care at the right time.
Yeah, no, I think that's beautiful. And I know I very purposefully asked you this because I was like, I think a lot of times you think, does it really differ as a physician? If you are serving different populations, different hospitals, what does that look like? And how does that change from site to site? So I appreciate you sharing a bit of that insight. So now I kind of just, as we kind of wrap up, you've shared a lot of nuggets and all of that. So I wanted to ask you, in your perspective, whether it is as a practicing physician, whether it is your role at CMIO, at SickKids, or as an adjunct faculty in academia, in the digital health space landscape, what are you most excited about? If there was one item that you were like, okay, this I think is incredible, this could help in X, Y, and Z. If you can, or multiple, it's up to you, however you want to take this up, or anything else that you want to share with the audience that maybe we didn't tap into and that you think would be important for them to know. So however you want to take this last question, I'll hand it over to you, but excited to hear what you have to say on that.
Well, I think the improvement in quality, some of the end-to-end workflows and some of the ability to use AI. And right now, AI is getting a lot of hype and it's getting a lot of hope. And if you remember something called the Gartner hype cycle, and we're at the peak of inflated expectations where AI is going to be to sell all these things, and we'll get to something in reality at some point in the future. But we do see the ability of AI helping. We talked about scribes a lot. We are also going to be piloting at some point in the future augmented responses to patient messaging as well. So I think AI is a really promising tool that's going to come forward. I think the appreciation of patient portals to be able to empower patients to be able to get us through and have them become partners in their care. I think we're seeing a lot of emphasis on that, and more patients now are going to be digitally literate. So their expectation is they want to have that Uber model or that app model for their care. And for complex care, that's going to happen. But what about for that episodic care? Everybody's got potentially an Apple Watch that potentially in the future will be able to tell their glucose monitoring as well. And you'll be able to drive your decision making through that. So wearables are a big portion of the future. I think COVID really brought in virtual care and the ability to get care virtually and not have to actually go in to see a physician all the time. Not everything needs a physician encounter, but why did things need a physician encounter? Because it was fee for service or it was very transactional based. So only if a patient came into the office would the physician get paid for it. So for simple things, the physician would ask you to come into the hospital, come into the office. But with virtual care, if the government participates and if we do it ethically and responsibly and people don't take advantage, I think we can use virtual care for that as well. So we talked about AI. I look at big data as well, being there. Again, peak of inflated expectations, and now we're looking at that. So I think the future is bright. I would suggest people, I love medicine. People say, Karim, would you still go into medicine? I said, 100%. I love what I do. And I look at my emergency work as being the least stressful part of my life. And I look at my CMIO work being the most stressful. But it's my safe space in the emergency department. And I'm grateful for the patients that give me the privilege to look after them. So it's really great. And I'm excited about the young people, including yourselves, who are getting into informatics as well. And so, yeah, I think it's going to be, I think the future is bright.
Yeah, no, and I appreciate you sharing all those pieces. I think it's so valid. Like you said, there's so much out there, but like you said, managing expectations. There's also that digital literacy, whether it's on the clinician side, whether it's the patient side. Like you said, there will be patient populations and clinician populations that will be, able to uptake that and adopt that, but also being cognizant of some populations that may not be, right? Social determinants of health when it comes to your patient populations. There's so much. And like you said, there's also waves like virtual care through the pandemic. It came through and it was adopted. And like you said, there's some care that can be done virtually, some of it cannot be, and being aware of all of that. I also love the piece where you said about AI. There's a lot of anxiety around it where it will replace jobs. I think even like in education or what have you, like you said, it is not to replace your clinicians. It is to augment their workflows. At the end of the day, it is going to be based on their discretion on how they navigate it. It can recommend X, Y, and Z. You get to choose, okay, does this make sense for my patient? Whether even in other fields. So I think it's important. I love that you highlighted that because I think there can be a bit of anxiety. There's excitement as well. So thank you so much for taking us on your journey where you said you were on paper files and how you kind of went through the implementation of EHRs, even in a different country, and highlighting those differences. And even when we learn from each other, how you said in the States, in Canada, in the Middle East, there are apples and oranges. You can learn pieces, but you have to be cognizant of the nuances and the differences. For example, the States is highly privatized. We have a public system, so you have to be cognizant of that. So I loved how you walked us through that and also highlighted some of the challenges that pediatrics, our children, are experiencing, how you guys are tackling that, and also tying it in with adult care that you do provide. So I appreciate you taking the time today to speak with us, share your journey, your insights, all those nuggets with us. So thank you so much, Dr. Karim Jessa, for spending time with us today. So yeah, thank you so much. Really appreciate it.
Well, I really appreciate the opportunity for this. Wish you well and happy to connect. Thank you very much. Have a great day.
Thank you.